The idea that depression is caused by low levels of serotonin is a theory. If what we are interpreting as improvement is sedation or emotional numbing, then we're not really looking at real improvement. When you tell someone that what they have is a medical condition, you take the meaning out of it. The profession has allowed itself to go along with the pharmaceutical industry line. It's allowed itself to be bought. Medicalisation of the problems of living is a convenient strategy because it diverts attention from the problems that are happening in the society.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being. Professor Joanna Moncrieff, your new book, Chemically Imbalanced, The Making and Unmaking of the Serotonin Myth, challenges some of psychiatry's most deeply held assumptions. It sent shockwaves through psychiatry and beyond, unsettling certainties and exposing how fragile some of our trusted narratives really are. In the book, you trace a history of antidepressants from the 1960s through the 1990s, when it took hold in popular culture. I could detect some key moments here: early chemical imbalance theories in the 1960s, then the Prozac era. Prozac is an antidepressant. Advertising in the 1990s. What is the story we were told about serotonin's role in depression?
So thank you for having me on your podcast, Hala. Just to start with why I wrote the book, I wrote it because the public have been fundamentally misinformed about the nature of depression and about what we know about its associations with brain chemical processes. So there's been this story around for a long time that depression is caused by a lack of serotonin in the brain or some sort of abnormality of the serotonin system. Whereas in fact, there is very little and certainly not a compelling or convincing evidence base for this idea. And yet millions of people have decided to take antidepressants because they were told that links between serotonin and depression were an established fact, or they were led to believe that in one way or another. So I wanted to tell people that these links are not an established fact. We do not know whether there is any connection between serotonin and depression, so that people can make more informed choices about whether to take antidepressants or not, how to understand the nature of their emotional feelings, and how to manage them.
But doesn't serotonin make me happy? This is the general understanding, right? If I have enough or healthy levels of serotonin in my brain, I'm bouncy and happy, right?
Yeah. So unfortunately, there is so much misinformation about all brain chemicals, including serotonin, and an impression is created that we know much more about them than we actually do. If you dig into the research on serotonin, you have to conclude that we are really uncertain about what on earth it does, other than it probably has some role in sexual functioning. It probably inhibits and impairs sexual functioning. Other than that, we're really uncertain. There is serotonin all over the brain, although there's more serotonin in our gut and in our blood cells, in fact. But the serotonin all over the brain, it's bound to be involved in everything that we do and think and feel for that reason. But we don't know what its specific functions are, other than this role in impairing and inhibiting sexual functioning.
Oh, so serotonin itself inhibits sexual function?
That seems to be the case. If you give people drugs that stimulate the serotonin system in some way, including, of course, the SSRI antidepressants, that's selective serotonin reuptake inhibitor antidepressants, it impairs people's sexual functioning. It reduces people's sexual desire. It reduces genital sensitivity. And it can cause, problems with getting an erection, having an orgasm, that sort of thing. And so there seems to be evidence that increasing serotonin or stimulating the serotonin system in some way has a negative impact on sexual functioning. But so people have also suggested that serotonin is involved in appetite, in sleep, in cognitive functions, as well as, of course, in mood. Yeah. But the evidence for any of those areas is really inconsistent, and we can't draw any conclusions about what specific role, if any, serotonin has in them.
Yeah, I would assume that if I take a drug, it must be based on evidence. So, but there is a popular imagination of depression as a brain illness. Now, can we talk about the assumed evidence that led to the use of antidepressants? Okay, what does the medical community rely on in using that proposition that, okay, you have low serotonin in your brain, and this drug fixes that, you no longer have depression? What is the evidence?
So thank you for asking me, because I think it's important to set out. I've just said there isn't much evidence for there being any links between serotonin and mood, as well as all those other areas of functioning that we talked about. But I think because people have been told for such a long time that a lack of serotonin causes depression, that serotonin has an important causal role in depression, it's important to really set out the evidence for that. And that's why I got a team together to look at all that evidence, to get all the modern evidence on serotonin and depression together. And we published a systematic review covering that evidence in 2022. So we got evidence. There are a number of different ways that people have looked at the activity of serotonin and its links with depression. The first thing to say is you can't measure serotonin levels or activity in the brain directly in human beings. It would be too invasive and dangerous. So that's not been done. So all the ways that people have tried to gauge the activity of serotonin are indirect in one way or another. People have looked, for example, at the levels of one of the serotonin breakdown products in the cerebrospinal fluid. That's the fluid that, yes, so serotonin itself is broken down very quickly. So to get an impression of serotonin concentrations, it's better in some ways to look at the breakdown products of serotonin. So that's why that's been looked at. And that's been looked at in the levels in the fluid that surrounds the brain and the spinal cord, which you can look at by doing a lumbar puncture.
So is this a direct correlation between having serotonin in the brain and the other chemicals in the brain? Is this reliable relation?
So we're not sure, but the levels in the cerebrospinal fluid are probably as direct as we get.
Okay.
Yeah, they're probably as close to the levels of serotonin in the brain as we can get. And those studies, they don't involve large numbers of people, but there are several hundred who've entered these studies and had lumbar punctures. And those studies do not show any link between serotonin and depression. They do not show that people who've been diagnosed with depression have lower levels of the serotonin metabolite in their cerebrospinal fluid.
Hi, I'm Hala, your host today. If you're enjoying what you see, please hit that lovely subscribe button. It will mean a lot to us. Or maybe a small podcast now, but with your support, we can build this channel together, one step at a time. Thank you so much for being part of it. And when doctors say you have low serotonin in your brain, low compared to what? Is there a baseline for it?
So they're comparing people with depression and people without depression. So there's an assumption that if you take a random sample of people who don't have depression, they will show normal, in quote, levels of serotonin in their brains. Okay, so before prescribing antidepressants, would my GP or psychiatrist be able to check whether do they do a lab test or any biomarker to check whether I'm actually low in serotonin or not? So doctors do not do that.
No.
And if they did do that, to measure serotonin directly, they'd have to drill into your brain. But even if they did a lumbar puncture and
indirectly, maybe,
or they could measure serotonin levels in your blood. But even if they did do that, they would not be detecting.
So there is no way
they would not be detecting depression, because we haven't shown those links between serotonin and depression. So I was talking about how we've got studies that have measured the levels of the serotonin metabolite in the cerebrospinal fluid. There are also some studies that have measured levels of serotonin in the blood.
Okay.
And they also do not show a link between serotonin and depression. There are studies that have looked at the serotonin receptors. Those are little proteins on the surface of the nerve cells in the brain that are triggered by serotonin and that transmit the serotonin impulse. And the studies on those also do not show consistent evidence of any abnormality in people with depression compared to people without depression. People have also looked at something called the serotonin transporter protein, which is a protein that is in what we call the synapse. That's the gap between the nerve cells. So serotonin is what we call a neurotransmitter. It's a chemical that transmits an electrical impulse from one nerve cell to another across this gap called the synapse. Now, there is a protein in the synapse, which we call the serotonin transporter protein, which removes serotonin from the synapse. So effectively, it deactivates serotonin. And it's that protein, in fact, that the SSRI antidepressants work on. They inhibit that. And therefore, the theory is that they will increase the concentrations of serotonin that remain in that gap between the nerve cells where it has its action. So that thereby they will, by doing that, they will increase the activity of serotonin. So there have been some studies looking at whether there are abnormalities of the serotonin transporter in people with depression compared to people without depression. Again, the findings are highly inconsistent. Some find there might be lower levels of that transporter protein. Some find there might be higher levels. Some find no difference.
So the medical community, sorry to interrupt you,
Yeah.
just for me to wrap my head around this, the medical community is prescribing antidepressants that supposedly increase serotonin in my brain, even though it hasn't been proven that I lack serotonin in the first place.
Yes,
Is that correct?
absolutely. And this is the really important thing for people to know. The idea that depression is caused by low levels of serotonin is a theory. It was a theory that was proposed back in the 1960s, massively promoted by the pharmaceutical industry in the 1990s, but it remains a theory. It has not been demonstrated to be true. The research that has been done to look at whether there are links between serotonin and depression has not convincingly shown that those links exist.
Inference, let's say, it's an inference or
an
construct.
idea, a speculation, a possibility.
Okay. But when I do take antidepressant drugs, do you agree that serotonin levels in my brain will increase, whether this is beneficial or not?
So I'm afraid that we also don't know very clearly what antidepressants do to the brain either. They certainly do something to the brain. They are chemicals that cross the blood-brain barrier, so they're going to change our normal brain chemistry by their presence. And there's some evidence that the SSRI antidepressants, because they inhibit that serotonin transporter, increase the activity of serotonin in the very short term. But actually, there's also some evidence that in the long term, taking SSRI antidepressants reduces serotonin. There are a few studies that show that the serotonin levels in the blood of people taking antidepressants are lower than serotonin levels of people not taking antidepressants, regardless of whether or not they have depression.
Yeah. And this was measured indirectly, as you told us.
So this is a measure of serotonin in the blood, not in the brain.
Yes.
So it's indirect in that sense. And these are people who've mostly taken antidepressants for fairly long periods of time. So what that suggests as a possibility is that SSRI type antidepressants increase the activity of serotonin initially, but then might reduce it.
Because it's a hormone.
Well, because the brain adapts to the presence of the drug, and the brain can often it's trying to neutralize the effects of the drug, the brain, but sometimes it can overshoot. Exactly. But on the other hand, as I said, one of the most consistently shown effects of boosting the serotonin system is sexual dysfunction. We know that SSRI antidepressants cause sexual dysfunction in people while they're taking them, and that sexual dysfunction doesn't generally just go away after a few days. It's an effect that persists, and it can in fact even persist after people stop taking the drug. So that suggests that the serotonin system has been ramped up in some way. The basic message is it's the picture is confused. We don't fully understand what SSRIs do to the brain at all. I think we need to pay more attention to the effects that these drugs actually induce in people, because that's what we can actually observe and measure and record. as I say, they're drugs that are changing the nature of our brain chemistry and activity, and therefore inevitably they do change our mental activity and our behaviour and our functioning in different ways. One of the consistent effects that antidepressants, particularly SSRI type antidepressants, have is they numb people's emotions. So people describe maybe not feeling so intensely sad anymore, but also not being able to feel happiness or excitement or surprise any longer. And that effect may also be associated with their effect on sexual functioning. They're just sort of dialing down our sensitivity, our sexual and emotional sensitivity.
It dulls the negative feelings and the positive feelings.
Yeah.
So I can't be happy. I'm emotionally dull or suppressed in a way.
Yeah.
Okay.
Yeah. So and just to say, this effect is very consistently reported by people who take these drugs. There's lots of literature about people describing these effects, and it's an effect that people describe to me in my clinical practice very frequently.
Can some people welcome that effect? Like, instead of being severely anxious and struggling with debilitating emotional pain, some people would rather not feel anything?
I think that's probably right. I think probably some people do welcome that effect. And and some people describe how they feel it's been helpful for them, at least temporarily. On the other hand, I would say that my impression is the majority of people actually find that effect quite unpleasant. It's a very common
long term.
And it's a very common reason for people stopping antidepressants.
Yeah, but it might be, from what I read online for the research of this episode, it might be why some patients find relief in these antidepressants. Like, some viewers might say, oh, antidepressant saved my cousin's life, it made me feel better. Temporarily, it's a side effect of the drug, and the drug doesn't actually fix some spontaneous biological defect in the brain.
So I agree with you. I think in theory, if you numb someone's emotions, that might be helpful, or it might be perceived as being helpful. The trouble is, and we'll maybe get into this in a minute, the evidence that antidepressants are actually helpful to people, are actually beneficial in terms of reducing feelings of depression and other problems that people have associated with those, is very slim. And I would say that actually that all those studies don't really show that antidepressants have any positive effects.
We established the fact that low serotonin in the brain doesn't cause depression, but is low serotonin in the brain a medical condition, or just a variation between a brain and another brain? If I have low serotonin in the brain, would that cause any harm physiologically?
So I think we just don't know. I mean, presumably there's variation between people in terms of their levels of serotonin. As I say, we don't really understand what serotonin is doing. We don't understand its specific functions. So I think it's very difficult for us to say whether, in theory, having low serotonin would be harmful or not. But there must be a normal range for it, as there is for all our brain chemicals and all our other bodily functions.
Do we know yet of any proven scientific biological cause of depression?
No, we don't. There are no proven biological causes. I think that's a very important thing to say, because along with the idea that low serotonin might be a cause of depression, numerous other biological mechanisms have been proposed. There are many other theories about possible biological mechanisms, such as, for example, there's been an idea over the last few years that depression might be caused by an abnormality of the inflammatory system. Abnormalities in something called neural plasticity, that's the ability of nerve cells to branch and make new connections, has also recently been proposed as a mechanism for depression. None of these things have been established as causes of depression either. And in fact, the evidence base for all these other theories is very much less than the evidence base on serotonin and depression, where there's, because of the antidepressants and the drug companies, there's been a lot of research into possible connections.
Yes, that's very interesting, because what I understand now that you're telling us, that the medical argument boils down to we haven't found a cause of depression, but it must be there, so we are assuming it's there. And there are a number of routes to try hard to find a biological cause of depression, but maybe there isn't.
Yeah, I'm glad you said that, because that absolutely nails it. There is an assumption within the medical community, or at least within sort of mainstream psychiatric community, that there is a biological cause of depression. And if it's not serotonin, it just must be something else, and we just haven't found it yet. We don't have to make that assumption. And it's not how we used to understand depression. If you go back to the 1980s, people understood depression as an emotional reaction to negative things happening in your life, as an understandable emotional state, something that had meaning, that happened for a reason. People might not always have been aware what the reason was, but it was something that could eventually be made meaningful.
Yes.
And so if you asked someone in the 1980s, in the late 1980s, what is the cause of depression? They would say unemployment, divorce, child abuse.
Trauma.
Lack of meaning. Bad things happening in your life, or yes, a lack of purpose and meaning. If you ask people now, they might well tell you that it's due to your brain chemicals or something happening in the brain because of the success of the promotional campaigns by the pharmaceutical industry to change people's mindset and convince people that depression is a medical problem. I think people still underneath have that understanding that actually depression is something that is a meaningful reaction to negative life events. But it's been suppressed to some extent by this medical framework that's been imposed from the outside.
Being masked, because publicity and marketing are very powerful things. And if the NHS, we'll talk about the NHS obviously, and the medical community, if your GP, you trust your GP, you go there for help. And if you refer to psychiatrists, that's even like second command, like it's not front care, that's even more specialized. You trust whatever you hear from them. They are in a place of medical authority. Why would I discredit anything a doctor tells me?
And this is why it's so important, I feel, to get across to people that the link between serotonin and depression has not been established. Because in order to persuade people to reject their underlying understanding of depression as a meaningful emotional reaction, they had to be led to believe that a biological mechanism had been convincingly identified, that it had been established, that it had been proven, that there was no question about it.
That's science.
And that is what the public have come to believe, that there is no question about it. It had been demonstrated, they thought. And that simply was not the case. And people should not have been misled in that way. People should have been informed that this remained at the level of a theory, and no one had demonstrated these links convincingly.
So why do you think psychiatrists hold on to that idea of biological mechanism to depression for such a long time without evidence? Surely they are way well informed and better researchers than patients like myself. Why do you think?
So that's a complicated question, and it requires delving into the history of the psychiatric profession. But just to sort of summarize it briefly, depression is a very common state of mind, and it probably makes up the vast majority of problems that are presented to psychiatrists. And so I think they feel if they didn't have a medical framework for this problem, then their reason for existence, the bulk of the work that they currently do would fade away, would disappear.
Yes.
And psychiatrists who started life as the doctors who ran the old asylums, the old mental asylums, have been trying to get away from the stigmatized status that those asylums acquired for a long time. And one of the ways that they've tried to get away from that is by cultivating an outpatient practice among people who have more everyday emotional ups and downs, rather than the sort of severe mental health problems that we might call schizophrenia or bipolar disorder nowadays.
Yeah, but the phrase chemically imbalanced might be debunked, but some viewers might still be wondering, why does it work for some people? Is it like we talked about the side effect or temporary relief? Is this like, how can we reconcile the individual experiences with the lukewarm data?
Yeah. So that's a really important point. And so I spoke earlier briefly about all the studies that have been done on antidepressants and how they don't show very convincing beneficial effects. Those studies consist of placebo-controlled trials. So they compare an antidepressant with a dummy tablet, a pill that's made of sugar or chalk or something biologically inert. Those studies show that people who take a placebo tablet get better. The majority of them get quite a lot better. People who take the antidepressant get a tiny bit more better when you're measuring symptoms using a very artificial depression rating scale. But the difference is very small. So the important point to make is that people who are depressed get better anyway, and giving them something that they think is going to work, giving them a pill, even if it's completely inactive, gives them hope and will help them to get better faster. So
people get better just because they expect to get better? So they feel hopeful that things will improve?
Yes. So the act of giving people a pill improves people's, makes people think, oh, at last I've got a solution. I think also it's important to say people often go to the doctor at a really low point. And, often people haven't wanted to go to the doctor. It's, they didn't want to. They wanted to try and sort things out on their own, and that makes them feel,
yes,
like a real failure. They go to the doctor says, take this pill. The patient experiences a feeling of relief. At last, now I've got an answer. It's not, it's not just that I couldn't manage to pull myself up. There's a medicine that's going to do it for me. And so that will produce feelings of relief, which I think, alleviate feelings of depression temporarily at least. But also often at that point, other things kick in. People admit to their, loved ones that they've been in a really bad place, and people,
yes,
people rally round.
They find the support, the social support.
Yes, exactly. So they find social support. They might, at that point, start to think, oh, I've really got to do something about this job that I hate and that's really been getting me down. Or maybe I need to, we need to go and get some relationship counselling, if that's a relationship problem has been part of the problem. So often at the point that people go to a doctor, other things are happening that are going to improve people's mood, as well as the hope that people get by being given a pill that they're told, will at least have some beneficial impact on them.
What kind of psychoactive effect do antidepressants have on my brain? We talked about sexual function, but how does this mechanism work that I feel emotionally dull or numbed or detached? Or physiologically, what's happening in my brain?
We don't know. We don't know the answer to that. Because increasing serotonin activity is bad for your sexual functioning and probably is playing some role in this reduction of sexual sensitivity and desire. I think we can speculate that maybe, increasing serotonin activity is what's responsible for emotional numbing, but we just don't know. And all these drugs are not that specific. Even the selective serotonin reuptake inhibitors are affecting other brain chemicals in various ways, not least because serotonin interacts with most of the other chemicals in our brain anyway. So if you are adjusting the serotonin activity, you're actually affecting all these other brain chemical systems. So the shorter answer is we really don't know how antidepressants, how their chemical effects translate into the experiences of emotional numbing or sexual dysfunction, or the other things that they cause. Some of them cause feelings of lethargy and demotivation. Some of them are, some antidepressants, not the SSRIs, but some antidepressants have more clear-cut sort of sedative effects. A common antidepressant that's used nowadays is called mirtazapine, and that is sedative in the sense that it sends you off to sleep.
Yeah, it controls symptoms rather than cure anything.
So if you're having bad, real problems with sleeping, it might help to improve your sleep. As I say, the SSRIs can make people feel a bit lethargic and a bit groggy, but they don't send people to sleep like a benzodiazepine like Valium would do, or like mirtazapine and some of the older antidepressants. The tricyclic antidepressants also had clear-cut sedative effects and were often prescribed to people for insomnia.
Yes, but doesn't that mean that psychiatry mistakes sedation for recovery?
So as I say, not all antidepressants have these clear-cut sedative effects. Some of them seem to have this, like the SSRIs seem to have this numbing effect, make people a bit lethargic, but they don't just send people to sleep or knock people out like a more standard sedative substance. But I would agree with you to the extent that if what we are interpreting as improvement is sedation or emotional numbing, then we're not really looking at real improvement. We're looking at the control of some experiences that might be difficult for people. And I'm not saying that that's wrong. It's people, I think, can make, a sensible decision that, maybe my feelings are just too much to endure for the time being and I need to damp them down. As long as they are making those decisions in an informed way, as long as they understand the consequences of taking that drug, especially if they end up taking it in the over a long period of time.
How many of us now in the UK take antidepressants? Do we have reliable figures on that?
So I think it's about 8.7 million people in England. The data is collated separately for England, Scotland and Wales. So yeah, about 8.7 million people, which is around between about 15 and 17% of the adult population.
Wow, and that's what's reported. Do you think it might be underreported?
I'm not sure how those data are collected, but in this country our data on prescriptions and healthcare is pretty good, so I wouldn't think it's substantially underreported.
Yes. You have written that, and I quote you, depression has acted as a template for the creeping medicalisation of a widening array of life problems. So we established the fact that depression is not a medical condition. How should we conceptualize it then? What is depression?
So I think our old understanding that depression is an emotional state, which is a reaction to negative things happening in our lives, it is the way that we should understand it. That makes it clear that it's related to us. It is part of what we are as a person. It's part of ourself. It's going to be because our moods are affected by what we like, what we care about, what we value in life. And if things that we like and care about are going well, then we will feel good. If they're not going well, then we will feel sad or anxious or demoralized. So I think that's how we need to understand. We need to understand it as a meaningful emotional state, a meaningful feeling state, if you like.
Yeah, response to life circumstances, whether it's trauma, loss, grief, whatever. Right?
I mean, that's what emotions generally are. They are a reflection of our sensitivity to our environment.
Yes.
They are a response to what goes, what we like and what goes well for us and what's going badly.
Is that why you said depression is a reflection of our values?
Yes, absolutely. So
that's quite
how we feel about our circumstances depends on what we like, what we don't like, what we value, what we have come to believe is important. And that, I think, shows you how our emotions are deeply interconnected with our personality, with how we have developed, what we've learned and been taught to care about and to not care about.
Yes. One of the key ideas in your book, Chemically Imbalanced, is that by medicalising depression, we have done a disservice to people. You write that over-medicalisation, and I quote you again, gives people false hope and leads to over-prescription of potentially harmful drugs that, at best, offer ways to stifle uncomfortable feelings. There is something here that tells me that you believe that uncomfortable feelings are an essential part of life or the human experience. Is that correct?
Yes, of course. And uncomfortable feelings, I think we can see as as being signals to us that something in our life is wrong and something needs to be changed. And as I said earlier, people, aren't necessarily immediately aware of what that is. I mean, you might be in a terrible situation with, being bullied at work or in a difficult relationship, and it's clear what's bringing you down. But it might be more subtle than that, and you might not be immediately aware. And our feelings are a signal to us that something's not right in our life, and we need to have a look round and try and find out what that is and make some changes. And just to go back to that quote as well, the problem starts because when you medicalize something, when you tell someone that what they have is a medical condition, you take the meaning out of it, because most of us understand a medical condition as being like having lung cancer or pneumonia or something like that. It's a biological process over which we have very limited control, and which plays itself out according to a set and predictable process. And that encourages people not to look for the meaning of their feelings. It encourages people to see them as if they were a medical disease, as if they were a biological state, and to rely on external treatments such as antidepressants or other sorts of physical procedures, rather than, as I say, trying to understand what those feelings mean, what they're signalling.
Yes, because if I'm led to believe that a pill could relieve my distress, I would put all my hope in that and perhaps not pursue other ways of help. Could this deflect attention from real problems in my life?
Absolutely. And, I think that sometimes we are diagnosing and treating depression in people who are in really bad circumstances, for example, in an abusive marriage. And by doing that, we are actually perpetuating that situation, because we're enabling people to think, oh, it's not my marriage, it's my brain chemistry, and I need to take this pill, and that's the problem.
I would think the antidepressants are keeping me going, but maybe the real issue, like an abusive marriage or soul-crushing job, that doesn't get addressed. Is there a line, I'm going to drill down a little bit, is there a line that we can draw between emotional pain or suffering that's part of the human experience and suffering that requires medical intervention? Or are you telling me, because some viewers might think, oh, it was a terrible time in my life, I couldn't function, couldn't get out of bed, couldn't look after my children, some people are in a very bad shape. Are you telling me that all emotional turmoil is simply part of life and I have to deal with it some way, as harsh as it might sound?
So there are obviously differences in the intensity of people's feelings. So some people can get into a very severely depressed state, whereas other people never get depressed at all. There's a whole range of intensity of emotions that human beings experience. The problem is that we, even for very severe cases of depression, we have no evidence that those are triggered or caused by a biological process. And we also do not have good evidence that biological interventions like antidepressants or other biological interventions are actually effective. Certainly not that they're effective in the long term. You've probably heard of ECT, electroconvulsive therapy, which is given to people with severe depression.
Yeah, would you please in brief explain this to our audience?
Yes, so electroconvulsive therapy is quite an old treatment that was introduced in the 1940s and 50s. And it was actually introduced for people with schizophrenia initially, but then then drugs for schizophrenia came in, and it became sort of redundant really in that area. But it persisted for the treatment of people with severe depression.
What does it do?
It consists basically of putting an electric current through the brain using 2 electrodes either side of the brain, to give people an electric shock, which induces an epileptic fit. So people have an epileptic fit. For that reason, people are given an anaesthetic and a muscle relaxant, so they're not aware of having the fit and so that they don't cause themselves any damage. Now, it does seem that ECT can occasionally, temporarily, literally jolt people out of a depressive state. I think that's because you're giving someone a mild brain injury when you're giving them an ECT, and part of the effects of that are that people lose their memory. And
wow.
And sometimes also people get into a slightly sort of disinhibited, fatuous state, almost becoming a little bit sort of manic. And that basically is superimposed onto their underlying feelings of depression. So temporarily, people's mood is lifted, but the evidence is that they sink back into the same mood state after a few weeks.
Yeah, I think that's what my mom used to have. She had. I'm almost certain that these sessions she had, we call them electricity sessions in Arabic back in Egypt. I don't think they helped a lot. They just made her very, very, very tired.
Yeah.
And she didn't continue with that treatment. Yeah, another nuance, please. What if depression is associated with suicidal thoughts or something like self-starvation? How do we treat it?
So again, the problem is that there's no evidence that antidepressants reduce suicide or that ECT reduces suicide. There's a little bit of evidence, in fact, that antidepressants might increase suicidal thoughts and suicide attempts in young people from randomized controlled trials. And so even if depression is associated with suicidal thoughts, that doesn't necessarily mean that taking a medical approach is going to be helpful. Now, I'm not saying that we shouldn't look after people who are severely depressed and or suicidal. Clearly, we need to, if people are really severely depressed and, can't get themselves out of bed, can't feed themselves, we need to look after them. We need to care for them. Almost everyone in that situation will get better eventually. So I don't think we need to go filling them full of antidepressants or other drugs or shocking people's brains. We need to look after people. We need to have patience. We need to keep them safe. We need to gently encourage them back into life again.
Yes, you just mentioned that using antidepressants might increase suicide rates. Did I understand this right? I mean, what is the mechanism here around this paradoxical effect that a drug that is supposed to relieve distress might eventually intensify it?
Yeah, so that's a really good question. And again, we've no idea what the brain mechanism of this is, but it seems to be that in young people in particular, some antidepressants anyway, can make them feel quite agitated. And as part of the agitation, some people get sort of ruminations, start ruminating, and sometimes they can have suicidal ruminations, and sometimes that can lead to people harming themselves. And randomized controlled trials that have compared people with depression taking a placebo and taking an antidepressant have shown that in young people, there is a slight increase in suicidal thoughts and self-harming behavior in those taking antidepressants compared to those taking a placebo. Because, of course, lots of people will be started on an antidepressant because they're feeling suicidal or because they're harming themselves. So it is quite difficult to disentangle what's happening. But there is this evidence from these randomized trials that suggests that the drugs can sometimes induce or worsen these effects. Yeah. And we really don't know how that, the mechanism, the biological mechanisms that drive those effects. And we don't know how that relates to the other effects of the drugs, the lethargy and the emotional blunting. Some people describe how the emotional blunting is sort of disinhibiting because people don't care about anything anymore. They think, I might as well just walk in front of the traffic. So it sort of disinhibits their suicidal, that disinhibits the restraint that they may have been using to stop their suicidal impulses.
I have a very interesting quote from the NHS. The NHS website says SSRIs will usually be the first type prescribed, like the first type of antidepressants, because the side effects are generally easier to manage and they are less likely, this is a funny sentence, I can't say it in a straight face, and they are less likely to cause serious problems if you take too much of the medicine. I've never read that before. Even if you take too much, it's going to be fine.
Right. So I'll explain why they're saying that. They're saying that because the older antidepressants, like the tricyclic antidepressants, which were developed in the 60s and which were the most commonly used antidepressants up until the late 1980s when the SSRIs came in, are highly sedating and highly toxic drugs. So you don't need to take too many extra pills to get a serious heart condition and die.
I see.
Whereas the SSRIs and these tricyclic drugs were strongly sedating, so they would knock people out. You know, that if you took a full dose that's prescribed for depression, you'd find that it was really quite difficult to get up in the morning the next day. People generally developed some tolerance to that effect, i.e. the effect wore off because there were changes in the brain that combated it. But nevertheless, these drugs had, you know, very noticeable what we might call side effects or effects. The SSRIs have much more subtle effects. Some people might not even really notice that they're taking a drug. Some people find it's only when they reflect back on how they were after they've stopped taking the medication that they realise how it was affecting them, because it was really quite subtle.
Some medicines have side effects as long as an arm. When I started estrogen, progesterone, the leaflet of estrogen is huge, totally scary. Some doctors might say it's a medicine. All medicines have side effects. Professor Moncrieff, you're a medical doctor. Are you making the case against antidepressants specifically or other medications as well?
I think the considerations that I think people have got to bring to bear on decisions about taking antidepressants apply to all medicines, okay? And it is true, all medicines have side effects. So you know, as an individual, if you're deciding whether to take a medicine or not, you need to weigh up whether the likelihood of these side effects and what they would consist of is going to outweigh the benefits that you might get from this drug. So this is why it's really important to stress that the benefits of antidepressants are very small and possibly nil compared to taking a placebo. So, you know, the considerations on the plus side are pretty slim. On the negative side, it is true in some ways that modern antidepressants have fewer strong side effects, strong immediate side effects compared to older antidepressants, but they do nevertheless have some common adverse effects that I think have not been widely enough publicised. One of these is dependence. They induce physical dependence. So when people try and stop them, particularly if they've been on them for a long period of time, they will get withdrawal symptoms. And those withdrawal symptoms, although they include physical symptoms like dizziness, and some people get these electric feelings in their head, like a sort of an electric shock. So you get those physical symptoms.
Spontaneously?
Yes, yeah. Very unpleasant, as I understand, as you can imagine. So there are these physical symptoms of withdrawal, but withdrawal can also produces emotional symptoms, particularly anxiety and panic and fear.
After I come off antidepressants.
Yes. Because if these drugs are suppressing your emotions and then you stop them, you get a sort of rebound effect that your emotions can bounce back even more intensely than they were before you took them. So people often describe when they're coming off antidepressants, they feel intense anxiety and they're very tearful. They're emotionally, up and down.
Everything's coming up the surface.
And emotionally sensitive, exactly.
I've come across the works of Professor David Healy, a long-standing critic of antidepressants, particularly the link to increased suicide risk. In one of his expert reports, he wrote, SSRIs can make an individual who may not have been likely to commit suicide before the onset of drug therapy, more likely to commit suicide now. Now, we touched on this. Will I find this side effect in the leaflet of my antidepressant and other side effects?
So I think you will now, but I'm not certain. But they certainly added the warning in America, and usually what they do in America we do too. How many people are actually alerted to this effect is another matter, because who sits and reads all the small print in your leaflet?
I would trust what the doctor is telling me, and I wouldn't read it.
As I say, I think this effect seems to be most likely in younger people. So I think it's quite a rare effect in general, but it does show up in the trials in younger people. Probably does also happen in older people, but again, I think that's that's even rarer, so very rare. Nevertheless, of course, suicide or suicidal behaviour is a really major concern. So, of course, people need to be warned about it.
Yes. I come from a Muslim background, and the Quran says, we have created man in hardship. Like the origin of creation itself is hardship. We were made in and for constant toil. It's not a brilliant idea. It's not the most pleasant one, but this seems to be the case. I mean, apart from childhood, hopefully, but once you start a family, that's real life.
And that it is through getting over hurdles and difficulties and challenges that we develop and that we flourish, isn't it? It's what enables our skills and our abilities to be honed, to come to the fore.
And from an evolutionary perspective, when we were hunters and gatherers, our brains sustained so much more. Stress was, I always say that stress was going hungry for days, or running from predators, or suffering 3-4 stillbirths in a row. This gives me hope that my brain can help me in difficult times, that I can overcome failing marriages, grief, a terrible job, that I can do this. But if the medical community is telling me, no, it's something in your brain, have this pill, this magic, beautiful pill, and you're going to be fine, that's a difficult job. We're asking patients for too much to be their own doctors. It's not fair.
I mean, of course, human history is, shows us how difficult human life has been for centuries. I think it was Hobbes who said human life is nasty, brutish and short, or something like that.
Life is not fair, Steve Peters.
Yeah. And we're very lucky to be born into the time and place that we are, and to have a much better, much easier lives, relatively speaking, than our forefathers. That's not necessarily true in all parts of the world, of course, with all the conflicts that are going on. And so, of course, people have always looked for a magic pill. People, there's always been this dream that you could take a pill and all your troubles would go away and you'd be happy forever. And, people have written literature about this, Aldous Huxley's Brave New World. So it is understandable that people are still attracted by this idea that there is a pill that will make you feel better and make your problems go away. But we know from history that there is no such thing.
And we prescribe pills for them to deal with problems that are maybe social or existential in nature.
In the past, probably most of the time, what people were given would be inactive and harmless. Nowadays, we are giving people real chemicals that really, change the activity, change the normal chemistry of your brain. That's going to have harmful consequences of one sort or another. Even if they're just minor harmful consequences. So handing out magic pills is a really serious thing nowadays. If you're handing out real chemicals for unrealistic hopes.
One of my favorite movies of all times is One Flew Over the Cuckoo's Nest. Have you seen it?
Yes, yeah.
It's a mad movie. I love it. It raises profound questions about human autonomy and power. Who gets to decide what's normal and what needs to be fixed? In your view, does psychiatry, at least in the UK here, balances well this dynamic relationship between authority and my rights, my autonomy?
So I do, absolutely, I think that happens. So psychiatrists haven't asked enough questions themselves. And so they are passing on a very partial view of human nature and human suffering to their patients. But they're not necessarily, that doesn't necessarily mean they're holding back things that they know that they could pass on. As we were saying earlier, I think many psychiatrists just assume that depression must have some sort of biological component, and they've not really asked themselves or thought deeply about whether we might be able to think about depression differently. They've not really questioned what the drugs that they're handing out are actually doing. So I think misinformation is out there is passed on to patients, but it's not necessarily given deliberately, because I think the people passing on the misinformation have been misinformed themselves.
Do difficult life events, the loss of a loved ones, again, failed marriage, trauma, severe stress, inequality, does that change my brain if I experience them negatively, I mean?
So everything that happens to us has an impact on our brain and biology, and there's also some evidence that trauma changes the brain in various ways, probably makes your stress response more sensitive.
Okay.
That's, it affects your whole body, not just your brain. So yes, negative life events affect our biology and affect our brains.
But there's nothing to fix it.
But no, we don't fully understand how. And of course, and as I say, that's, everything that we do affects our brains. And affects our biology. It's not just major traumatic events. I'm sure that having good experiences affects our biology and our brains too.
Yeah, true. I think I shared with you off air that I took antihistamines for a period of time, 2 months or 3 months, and even the innocent looking antihistamine affected my brain negatively. I couldn't walk in a straight line. And antihistamines, they're everywhere. And I remember when I text one of my friends telling her about that, because she has severe allergy, she used to take them. She told me that I give them to my child. She's 9 years old. Whoa. And I'm pretty sure I had some sort of dependency on them, because without them, my sleep was even worse. But I use AI, basically, Gemini. Gemini is brilliant in helping me manage the negative brain symptoms of the antihistamine, and they recommended approaching my GP, take lesser dose for a number of weeks, then coming off completely, and I managed eventually. But it felt like a huge weight on my brain. My balance was totally off. There was a huge fog on me, and that's just antihistamine. So I can just imagine the terrible side effects of something like SSRIs. You have coined the terms disease-centered model versus drug-centered model in relation to how psychiatric drugs work. This is central to your philosophy. Could you please explain to us in very simple details the difference between them? Talk to me like I'm a child. So.
Yeah, I'll try. And I think this is a really important point, and it reflects on the previous point that we were making, this, because psychiatrists are so signed up to this disease-centred model of drug action, they're passing that on to patients, and they're, I think, for that reason, not appreciating the real nature of the drugs they're prescribing. So this disease-centred model is the standard medical idea that drugs like antidepressants or antipsychotics or drugs that we prescribe for people with bipolar disorder work by targeting some underlying abnormal mechanism that is leading to the symptoms of the condition. It's a model that is borrowed from general medicine, where most drugs do work in that way. Now, it's not just that this model is not just saying that the drugs should be should be curing the condition, should be targeting the ultimate cause of the condition, because something like the Ventolin in your asthma inhaler, the drug that's in your asthma inhaler, I would say it works in this way too. It's not treating the causes of asthma. What the Ventolin does is it relaxes your airways, which have become constricted that's what causes the wheeze, that your airways have tightened up. And the Ventolin relaxes the airways, so the wheeze goes and you can breathe normally again. So it's not combating the cause of the asthma, but it is targeting the mechanisms that produce the symptoms, that produce the wheezing.
This is a drug.
So this is the disease-centered model. Okay. Now, so that is how drugs like antidepressants are assumed to work. It is assumed that there is some underlying biological mechanism, like the constriction of the airways in asthma, and that the antidepressant reverses that and thereby improves the symptoms of depression. But there's another explanation for what drugs like antidepressants might be doing for drugs that are prescribed for mental health problems. And this is the idea that they are having psychoactive effects, that they, and we've sort of led up to this by what we've been talking about before. This is the idea that these drugs change the normal state of the brain. They change your normal brain chemistry. They put it into a different state compared to how it would be if you hadn't taken the drug. And they do that in anyone, not just someone who has a condition, but in anyone who takes the drugs. So anyone who takes, for example, let's take an obvious example, a dose of Valium, a tranquilizer called Valium, will feel substantially different. They'll feel calm. They might feel a bit sleepy, depending on how much they've taken. They might stagger a bit if they've taken a lot, because Valium has quite similar effects to alcohol. They might feel a bit less inhibited and a bit more social at lower doses. So those effects are not arising because Valium is treating some underlying chemical imbalance. They are arising because of the effects of the drug on the normal state of the brain. And anyone would experience those, like anyone experiences the effects of alcohol, although of course there is individual variation. So what I am saying is that drugs that are prescribed for mental health problems need to be understood like that. We need to understand how they change our normal mental states and feelings and behaviours, in the same way that we would understand Valium, alcohol, cannabis, etc. Okay? Now, we've already talked about how drugs like antidepressants come from lots of different chemical classes and produce different sorts of alterations. So the older antidepressants, particularly the tricyclic antidepressants, have sedating effects, make people feel quite sleepy and drowsy, and, as I said, are prescribed for insomnia, in fact. And they are quite different from the effects of the SSRI antidepressants, the more recent, the more modern antidepressants, which don't have profound and immediate sedative effects, although they do often make people feel a bit lethargic. But they do have this emotional numbing effect, which is probably connected with the sexual numbing effect that they've been shown to have. Then there are drugs called SNRIs, selective serotonin and noradrenaline reuptake inhibitors. So they're meant to work through by increasing the activity of serotonin and noradrenaline, which is another brain chemical that's been proposed to have a role in the onset of in causing depression, although the evidence on noradrenaline is no more convincing than the evidence on serotonin. These drugs make people feel really quite groggy and foggy.
Yes.
Although, again, they're not classical sedatives. They don't just send people to sleep. So the important point is different antidepressants have different sorts of effects. And obviously, these effects will interact with how someone is feeling. So if you take something that really sedates you and sort of wipes you out, you probably won't be quite as in touch with your feelings as you were without it, because you'll actually be just overwhelmed with fatigue and sleepiness. If you take something that numbs your emotions, then of course your feelings of sadness or distress won't be so intense. So this is what I'm calling a drug-centered model. It's the idea that the effects of the drug on the normal brain produce mental and behavioural effects that interact with our underlying feelings and difficulties, and may make them feel easier to manage, or may just obscure them temporarily, replace them with feeling drugged. We can understand this effect again if we go back to the effect of alcohol. If you're feeling really down or really stressed about something and you go out and have a ton to drink, your worries go away temporarily, your sadness temporarily goes away because you're under the influence of the alcohol. I'm not saying that psychiatric drugs like antidepressants are exactly the same as alcohol. Clearly they're not. They have different sorts of effects, but the principle is that they change our normal mental state and behaviour, and those changes are superimposed onto what people are feeling underneath. Another example that I think is useful to give is the example of opiate anaesthetics like morphine, for example. So these drugs have some direct directly target pain mechanisms, but they are also what we might call psychoactive drugs, mind-altering drugs. They put people into a different sort of mental state, an altered mental state. And one of the characteristics of this altered mental state that is induced by opioids or opiates is feelings of emotional indifference. So people who've taken opiates for pain will often say that they still have some pain, but they don't care about it anymore. And that aspect of their effects is what I would call a drug-centred effect. It's an effect that is induced by the mental alterations that the drug produces rather than a targeted action on a particular causal mechanism.
So in relation to depression, sorry if I'm overly simplifying this in a very naive way, the disease-centered model is like, okay, I have this is a very bad analogy, so bear up with me. I have, my bike has a broken part, a broken wheel. The mechanic fixes the wheel. The bike is fixed and working again. And this is what some psychiatrists are relying on in justifying giving antidepressants. You have low serotonin in the brain. That's an automatic change or fault in your brain. Antidepressant fixes that. You're cured, and you obviously challenge this idea. Whereas the drug-centered model is like you mentioned alcohol, or you're sad and exhausted, you have some wine, you feel better, but that doesn't mean that you had wine deficiency.
You haven't fixed the bike. No, that's right.
No,
yes.
You haven't fixed anything.
Yes.
And in relation to depression, this might sound like a doctor saying this medication, this antidepressant will change your brain function. It has some side effects. It might make you feel detached or sleepy. It might bring some relief, but you're not cured. This is the drug-centered model, and you advocate viewing antidepressants in this framework of drug-centered.
Exactly. I advocate viewing all of the drugs that we give for mental health problems in this model, because we know that these drugs have effects on the brain and affect our mental states as a consequence of that. That's not in dispute. And we have not identified underlying causal mechanisms that they might be targeting. So obviously, viewing their effects in this way, it seems to me just has to be our default way of understanding the nature of drugs like antidepressants. But also, this applies to the use of stimulants which are prescribed for ADHD. It applies to all the drugs that are prescribed for bipolar disorder and drugs that are prescribed for psychosis or schizophrenia.
This is a bit of a dramatic question, but are you advocating for psychiatrists not to use drugs or do you think it's more useful for them not to use drugs?
So, no, I'm not advocating for that. I think that some drugs have useful effects in some situations, but we don't understand the effects of drugs well enough because we've had this idea that what they're doing is targeting underlying mechanisms, and therefore we haven't shown enough interest in the sorts of alterations that they produce and how those alterations might or might not be useful. I'll give you a couple of examples where I think drug treatment can be helpful and why. So someone who is having a manic episode, someone who we might say has bipolar disorder and suffers from manic episodes, often they will not sleep for long periods of time and they'll be over-aroused and disinhibited, and as a consequence do silly things. And they often therefore end up in hospital or picked up by the police. In that situation, giving a drug that reduces arousal and helps people to sleep and calms people down is a useful thing to do. It's probably not good for the body, let alone the mind, to be, constantly hyper aroused and hyper alert like that and not getting any sleep. So that's a situation where I think a drug can be useful. It's not because it's correcting the cause of their mania or their bipolar disorder. It's because sedative effects are useful. Drugs with sedative effects are useful in that situation when someone is hyper-aroused and not sleeping. Another situation where drugs, I think, are useful is when someone is acutely psychotic and preoccupied with unusual ideas and beliefs and maybe hearing voices or having other strange experiences. Drugs that we call antipsychotics, but we used to call major tranquilizers, again, help to tranquilize and calm people, but they don't just send people off to sleep. These are drugs that seem to be able to dial down neurological activity without just sending people to sleep. And one of the consequences is they again induce a state of emotional indifference, and people care less about their experiences. They're less invested in them. They're less interested in their delusional ideas and psychotic experiences. And again, if someone is really, in the throes of an acute and intense psychotic episode, dampening it down in that way with these drugs can be useful. So I think I'm trying to illustrate that we really need to understand in a much more sophisticated way than we do at the moment the effects that these drugs have in order to match them up and to the situations that people are experiencing. But we also need to acknowledge that they are drugs, they are changing the normal state of our brain chemistry, and particularly, and if you do that over a long period of time in particular, there will often be negative consequences. We know this from people drinking significant amounts of alcohol for long periods of time. It's not good for you generally. And so, of course, we need to bear that in mind when we're using the drugs, plus all the other negative effects that they can have, adverse effects that they can have.
You talk about long-term use. Of course, if psychiatrists put SSRIs in the framework of disease-centered model, you will continue to take the drug, because if you don't, well, the illness will come back. So this will automatically lead to long-term use.
Yeah, and it also leads to long-term use because people become afraid that because they've been told they've got a chemical imbalance, or they've come to believe they've got a chemical imbalance, they therefore don't think they can stop the drug. And therefore they go on using it. If they try and stop, they may well experience some withdrawal symptoms. Because those symptoms are often emotional, they may think they're having a relapse, and then they end up taking the drug for long periods of time. And I've shown in some recent research that people who believe that they have a brain chemical imbalance or some other biological abnormality are more likely to take antidepressants for longer, and that's regardless of how severe their symptoms are.
All right, so whether I respond positively or negatively to SSRIs, surely I shouldn't be taking them forever. At some point, I should stop, right? I have come across the works of psychiatrist Mark Holowitz, who said he almost died coming off antidepressants because of severe withdrawal effects. He has an article in the New York Times, we'll put the link in the description, in which he said thousands, perhaps millions of people who try to quit antidepressant drugs experience stinging withdrawal symptoms that last for months to years. Insomnia, surges of anxiety, even so-called brain zaps. Is that what you were referring to?
Yes,
brain
yes.
zaps?
These feelings of like having an electrical shock in your brain. Yeah,
sensations of electric shock in the brain. What do your patients report about withdrawal symptoms? And I want to know the difference. I mean, if I take antidepressants for 2 years, for example, would I get more severe withdrawal effects than if I take them for 6 months? Would it make a difference?
It's probable that if you've just taken antidepressants for 6 months, you won't get really severe or significant withdrawal symptoms. But antidepressants do differ actually, and some antidepressants seem to be able to induce some degree of withdrawal symptoms even after quite short-term use, particularly the SNRI antidepressants. that's the serotonin and noradrenaline reuptake or antidepressants. The individual drugs are venlafaxine and duloxetine. For some reason we don't completely understand, although it's probably in part related to the fact that they have a short onset of action and are quite rapidly excreted from the body as well. They seem to cause withdrawal symptoms more frequently and withdrawal symptoms that are more severe.
Yeah. Is the implication here that SSRIs might cause physical dependency similar to maybe addictive drugs?
So absolutely, they do cause physical dependency, and these withdrawal symptoms, both the physical and the psychological withdrawal symptoms, are a consequence of physical changes in the brain. So, if you're taking these drugs for a long time, just as you said when you were talking about your antihistamine, how you, after taking that for a while, you found it then difficult to get to sleep when you stopped it, and had what seemed like a withdrawal state. What was happening there and what is happening in people who are using antidepressants for long periods of time is the brain is adapting to the presence of the drug. It's basically trying to neutralize it, trying to cancel out its effects. So then if you take the drug away, the brain is in a different state, and the drug that was compensating for these changes that have occurred is no longer there. And therefore you get withdrawal symptoms. And those symptoms can include anxiety, panic, fear, feeling very emotional, tearfulness, irritability, low mood, lots of emotional symptoms, as well as physical symptoms, as well as dizziness, nausea, headache, and these characteristic brain zaps. So this definitely is a state of physical dependence. Now, there's a lot of confusion in this area. We've known that antidepressants cause this state for a long time, actually, but it was always underplayed because they are not drugs that give people a buzz or make people feel particularly nice or high, and therefore people don't want to sort of keep increasing their dose or go out and try and, buy illicit stocks of antidepressants on street corners, as they might have done with Valium and the benzodiazepines that have effects that are more commonly experienced as being pleasant and desirable. So they're not drugs of abuse in that way. People, not going to be, shoveling them back to get a quick high. That doesn't mean that they don't cause dependence, and cause dependence at the doses and levels that they are prescribed at.
Yes. So I experience these withdrawal symptoms and I struggle. When I go back to my GP or psychiatrist, what will they do? Will they instruct me to go back to antidepressants again?
So we think that what's been happening very often is that people stop taking their antidepressants, experience withdrawal symptoms, and either assume or are told by their doctors that they're having a relapse, are put back on the medication, and then they feel then they can never come off it. They feel that they've failed to get off it. It's been demonstrated to them that they need it forever.
That's not good. Okay, I think it's time for us to, if you could please give us a small guide or a long guide on how to come off antidepressants responsibly and safely.
Yeah. So linking back to the previous point, the first thing that people need to understand is that they may experience withdrawal symptoms when they come off antidepressants. It's really important that they understand that the emotions that they have are not necessarily a relapse of their previous problem, but are very likely to be due to the fact that they're reducing the drug and their brain is having to get used to lower doses of the drug. So it's really important to educate people about the possibility of withdrawal symptoms, and those will be more likely to occur if people have been using the drugs for a long time, for years rather than a few months. So that's the first important thing. And if people have been using drugs for just a short period of time, they could, they could try reducing the dose a bit, see if they get any withdrawal symptoms. If they don't, they could carry on and they'll probably be able to come off it relatively easily. If they've been using the drug for longer periods of time, certainly if, over a year or a couple of years in particular, they need to be much more careful. So I would suggest that people start by making a small reduction, see if they get any negative effects, if they experience any withdrawal symptoms by making a small reduction. If they don't, they could continue at the same pace. But the important thing is that people, particularly people who've been on drugs, these medications for long periods of time, the important thing is that they slow up the rate at which they reduce as they reduce the dose. That's what it means to reduce in a hyperbolic way. That's the work of Mark Horowitz has emphasized how drugs are excreted from the body in a hyperbolic sort of exponential way like that, rather than in a linear way.
Okay.
So the reductions that you make when you get down to low doses have a much bigger impact than the reductions at higher doses. So when you get down to low doses, you need to reduce very, very gradually and very carefully. And the reason why this is important is because some people who come off these drugs suddenly or too fast seem to get into a really terrible protracted withdrawal state. Some people refer to this not as a withdrawal state, but as a state of brain injury, as the consequence of a brain injury. We don't know, what's causing this, but it's definitely related to coming off these drugs. It happens to people who come off antidepressants and benzodiazepines in particular, possibly with other drugs, but those are the two that it's been most consistently reported. And people in this state report ongoing problems with fatigue, brain fog, muscle weakness, muscle twitching, anxiety and emotional problems. So and these symptoms can be really significant and debilitating. People have to stop work or cut down on their work. They can lead to the breakup of relationships. So it's really can be a devastating state to end up in. Although I think people do gradually get better, even it can take years for people to get better, to recover from this state. So that's why it's so important that people do withdraw very carefully and not go too fast, especially down, at those lower doses.
Yes. On a practical level, I appreciate that this subject is it's more complicated than this. Where do I go for a thorough, detailed guide on how to stop antidepressants? Is there a reliable source for this?
So the best place to go would be the Maudsley Deprescribing Guidelines, which have been written by my colleague Mark Horowitz.
Okay.
Who specialises in how to help people withdraw from these drugs in a safe manner. They're very comprehensive. They're written for practitioners rather than lay people, but they have lots of very useful tables in them and advice on how to reduce doses slowly, how to get small doses when you might not be able to get tablets that are very low dose, how to convert to liquids and things. So
when I get tablets, simply ask my GP that I've decided to do this and that. Can I have a lower dose, please? Would that work?
So the trouble is with some tablets, there aren't very low doses. So you may have to convert to a liquid preparation, or you might have to resort to cutting tablets up or dissolving them. There are various ways of doing it to try and achieve small doses. So the Maudsley Deprescribing Guidelines is has the most detailed help and advice. The Royal College of Psychiatrists website has some quite helpful advice on stopping antidepressants. It's not as detailed, but it does set out some of these principles quite well. And it was also written by Dr. Horowitz. So
okay. We'll put both links
source
in the description. Yeah. We touched on your paper that in 2022, you and your colleagues published a paper titled The Serotonin Theory of Depression, a systematic umbrella review of the evidence that was in the scientific journal Molecule Psychiatry. It's very hard to find the link of that paper, but I found it and we'll put a link in the description. When this paper came out, it was reported worldwide. It was read by 1 million people. Did you receive any valid, sensible criticism of this paper?
We received a lot of criticism and a lot of angry responses. And the first responses were, and these were from psychiatrists, generally. And the first criticisms were, we knew this all along, why did you bother doing this? It's not important. And then the next criticisms were, you didn't do it properly, and there is evidence after all. So completely contradictory messages. Of course, when you do a review like this, you're making lots of decisions about what to include, what to exclude, how to evaluate the data, and you can always make different decisions. And so, we were criticised for using certain quality scales and how we applied them, and for not including some studies and including other studies. I am confident that review was a high quality review, partly because we had several people in the team who are experts in doing systematic reviews, and we followed the most up-to-date guidance on conducting these sorts of reviews, and we also mimicked several other high-quality reviews that have used the similar methodology. So I'm confident that it was a good quality review, but lots of sort of minor trivial criticisms were made, most of which actually were completely inaccurate. They accused us of missing studies that we hadn't missed, or including studies that we shouldn't have included but actually fulfilled our inclusion criteria.
Yeah, I read online that some psychiatrists try to revive other biochemical explanations, like focusing on new brain targets or calling the chemical imbalance idea a mere metaphor. What do you make of this resilience?
So I think it shows the desperation of parts of the psychiatric profession to maintain the public's belief that depression has a biological origin. I think although they know full well that has not been demonstrated, they want people to keep on believing it. I mean, I was told by certain colleagues of mine that I should not be publicising this paper, I should not be talking to the public, I should not be talking to the press, that it might put people off getting help and people wouldn't necessarily be able to properly understand the information. So I think there was a concerted effort by sections of the psychiatric profession to shut down any discussion that might encourage people to question the dogma that they had been led to believe, that depression is caused by some sort of brain mechanism. Because I think it would just be too awful to contemplate that, all these millions of people have been started on ineffective and harmful substances at their instigation.
Yeah. I think it's just part of human nature to hold on to our stories. We build the whole identity around stories. But that's what medical doctors do. They prescribe medications. They don't talk to you out of an illness. They don't prescribe breath work. They find pharma solutions. It's part of how they function, which is fine in most cases. But in this case,
I think the profession really needs to look at itself, though, because what has happened here is the public and the profession have been misled by the pharmaceutical industry. And the profession has allowed itself to go along with the pharmaceutical industry line. It's allowed itself to be bought with, all the money that was dished out in the 90s and the noughties at psychiatric conferences and to psychiatric key opinion leaders, and in providing education for GPs and psychiatrists. It has allowed itself to be misled, to be taken along with this myth that the industry created, that there was evidence for a chemical imbalance in depression.
Yes.
And the profession really needs to, I think, sit up and realise that it needs to guard against that sort of situation. It needs to stop it happening in the future. It needs to have mechanisms whereby it can be more critical of what the pharmaceutical industry is telling it.
Yeah. But medical doctors are scientists at the end of the day, and science evolves. Yeah. We know new things now, today. I think someone here in this podcast mentioned that the scientific cycle is 28 days. Every 28 days, things change. Yeah, because we have research, we have clinical trials, and we're human beings with evolving brains. But patients assume that drugs are proven to work. Do you see this as a betrayal of public trust?
Yes, I do, because we've known for a long time that the serotonin theory of depression was not supported by evidence. As the people said who were commenting on our paper in 2022, this is not surprising. We've known it for a long time. That's true. We have known for a long time that this is not an established fact, and we allowed people to go on believing that it was. And we've also known for a long time, although people still push back on this a lot, that antidepressants really don't have any significant beneficial effects.
Well, it's one thing for a commercial entity to follow profit at the expense of whatever. Another thing for many medical doctors, and I quote you again here, sorry, perfectly happy for people to go on believing in the fiction of the chemical imbalance. SSRIs became, when I researched this, they became $1 billion blockbuster drugs kind of thing with a promise of an easy fix. Is money that powerful?
Well, I think this story illustrates that it is. And it's a similar story to the opioid crisis in America, where, a drug company saw an opening to make profit, managed to persuade large sections of the medical profession that its new drug, although it was an opioid, didn't make people dependent like other opioids did, wasn't going to cause the same problems. And of course it did. It did make people dependent, and we ended up with the opioid crisis. And it was that company's money that persuaded the medical profession, to go along with the promotion of this drug.
There have been a number of scandals around antidepressant research and clinical trials, including the STAR-D trial and Study 329. Both raised serious concerns about how clinical data are reported. What happened in both of them, please? Let's start with STAR-D.
So the STAR-D study was a very large study of antidepressants conducted in the US. It wasn't funded by the pharmaceutical industry. It was funded by government grant funding body. It involved 4,000 patients. It wasn't a placebo-controlled trial. It was a study in which people were all started on an antidepressant and then started on another antidepressant if that didn't work, and some group of them were given therapy at one point, and people were followed through these different stages of their treatment up to a year after it started. And it was first reported, I think, in about 2004, and it was said to have very good results. Over 2/3 of people showed a remission of their symptoms.
After using antidepressants.
After using antidepressants after the first 3 months, I think. And it's gradually come out in subsequent publications over the subsequent 20 years that, in fact, that initial picture that was painted of the results was much too rosy and was based on cherry-picked data, selected data that showed positive effects, and the actual outcomes that had initially been nominated to be the main outcomes had been suppressed, had not been published because they were less positive about the effects of antidepressants. And the main outcome, which was based on the Hamilton rating scale for depression, I think that's right, it might have been the Madras. Anyway, one of the main depression rating scales has actually only been published recently by a separate independent group who were eventually given the data from the STAR-D trial and did their own analysis. The original authors never published it. what they used in their initial publication in 2004 was a subsidiary scale that it was intended just to guide the doctors who were administering the treatment. It was never intended as a proper outcome measure, but they'd used that in their main publication, presumably because the other outcome scale didn't show very positive findings. So the final results were published a couple of years ago, and they show that the improvement in terms of when you look at the depression rating scales that were always intended to be the outcome, there is an improvement, but it's not a very substantial improvement. It's probably no higher than it would be than placebo groups in placebo-controlled trials, although this is probably a slightly different group of people in this study than in your typical placebo-controlled trial. And then one of the most powerful publications, again by an independent group, showed that out of the 4,000 people that went into this study, only a couple of hundred, I think it's 3 or 4%, 3% I think, of the original total actually got better and stayed in the trial for the whole year of follow-up. Other people either never got better and then relapsed, or dropped out of the study. And we should remember that this study offered people free and good quality healthcare, so there were a lot of incentives for people to stay in the study.
Now, I'm trying to understand this. So this was government funded, and it was a fault in the process itself, in definitions, or was it, do you think, a deliberate attempt to mislead the public?
So the main problem seems to be at the point of publication, and it seems to be that the authors selected data that would put antidepressant treatment in the best possible light,
cherry picking,
and decided not to publish data that showed it not to be as good.
Okay, we will not assume ill faith.
Yeah, and this is, selective publication like this is very common. The problem has probably got better over the last decade or so since the idea of registering a trial has come in. So now most trials that are conducted are registered, and you have to declare up front what your main outcome measure is going to be, and then you have to publish it, or most journals would demand that you publish that outcome measure when you publish. This trial, I believe, was not registered up front in that way, so it's only subsequently that we've found out what the main intended outcome was planned to be.
Yeah. What about study 329? What happened there?
So study 329 is a study of paroxetine in adolescents with depression, and it was conducted by the pharmaceutical company, and it was initially published again sometime in the noughties. I can't remember the date of the first publication. So when it was first published, it was said to show that the antidepressant was safe and effective for adolescents with depression. So what happened first of all, I believe, is that a group of researchers based in Australia got hold of internal communications of the drug company. And this showed that the drug company had been discussing how to deal with the fact that they had a negative outcome. And there were various different versions of the publication that were drawn up that used, again, selected subsidiary outcomes that put the drug in a positive light and didn't mention negative outcomes. And the paper that was finally published did mention the main outcome, that was the outcome measure that was meant to be the main outcome, but only in the small print. And it highlighted other outcomes that had been devised after the results had come in order to find a positive effect.
Yes.
And the email trail shows how the drug company scientists and analysts played about with the data until they found a positive effect that they could publish. So this was very shocking. Eventually, the data were reanalyzed by an independent group who found that the effects of the drug were small and not clinically significant, and that there were lots of adverse effects that had been played down again, hadn't been highlighted.
So between the officially published claims of the clinical trial by the pharma company and the reanalysis, how many years was paroxetine still being prescribed?
So paroxetine is still prescribed, yes.
Despite the
amount that it's prescribed in general has gone down because it is one of these drugs that causes the worst dependence and withdrawal effects. So it was very commonly prescribed in the 1990s, and then from sometime in the noughties, the rates at which it's prescribed start to go down. But it's not banned. It is still prescribed.
It defies logic that the antidepressants work narrative still exists while we have some scandals around whether they are effective or not, because usually we introduce drugs based on clinical trials and data. If there is no basic scientific data, we have nothing really.
So maybe we're coming on to this, but the justification that people always use for the use of antidepressants are these placebo-controlled trials that find a small, if you put all the results together, find a small advantage of antidepressants over a placebo. The trouble is that small difference is, first of all, almost certainly not clinically relevant. It's a small difference on symptom scales. It's a 2-point difference, for example, on the 52-point Hamilton rating scale for depression, and no estimates of what difference in symptom scores might be clinically significant, gets as low as 2 points. But the other thing to say is that small difference may not actually be a real pharmacological effect. It may well be because people in randomized controlled trials of antidepressants and other similar drugs can often guess whether they're getting the real drug or whether they're getting the placebo on the basis of side effects, such as having a dry mouth or feeling a bit different, feeling a bit numbed or a bit groggy. And we know that people who guess they're getting the active drug do better than people who think they're getting the placebo. And so the fact that people can guess is going to mean that people who are taking the antidepressant get what we might call an amplified placebo effect, an extra boost because they think, I've got the real drug. Yeah. I've not got the placebo. And there is evidence that effect may account for this small difference that we see between antidepressants and placebos.
When pharma companies run medical trials, how do they report it? I mean, how do ministries of health make sure that the results are transparent? Do we have guidelines around this?
So the regulators, the drug regulators, in the UK it's the MHRA, Medical and Health Appliances regulator. In the United States it's the FDA, the Food and Drug Administration. Now the FDA criteria for approving a drug are that there are 2 positive studies of that drug. There can be 50 negative studies. If you've got 2 positive studies, then you will get approval as long as as long as there aren't catastrophic side effects.
Oh,
so it doesn't mean very much that a drug is licensed, that a drug is approved. And in the case of antidepressants, a positive effect, as I explained, can mean a statistically significant difference, which is based on a tiny difference between the actual drug and the placebo that has actually no clinical relevance.
Yeah. What reforms would you suggest to ensure that psychiatric trials are transparent and not subject to those who have a stake in selling treatments?
So we've had some of the reforms with the introduction of trial registers and trials having to be registered in advance and people having to specify what their main outcomes are. And I think most journals, most decent journals now will demand that they see the protocol, the original protocol for the study, and to make sure that people are, and the trial registration, to ensure that people are reporting the main outcomes that they nominated at the beginning, and they're not cherry picking or devising outcomes, after the event, after the data's collected, to try and reflect the effect that they wanted to see. So that's a really positive thing. The problem with psychiatric trials, with trials of things like antidepressants, I think goes deeper than regulation, really, because it's about how we conceptualise mental health problems, and that influences how we think we can measure them. So we have, because we are treating mental health problems as if they were physical diseases, we behave as if we can measure them in a meaningful way. And I think we really have to question that. We've devised these scales which put together, arbitrary collections of possible symptoms that someone with depression might have. I mean, just calling them symptoms is a loaded term to begin with. And then we think we've measured the severity by getting people to rate these individual symptoms. Now, just to give you an example, one of the symptoms in the Hamilton rating scale for depression, which is the most commonly used or has been historically, is just a question that asks people to rate their mood. How do you feel in terms of your mood? And people who say they feel depressed, but are not particularly showing depression with their body language, get a rating of 1. People who are showing depression with their body language, who are crying or being emotional, being very emotional, get a rating of 2. They get a higher rating. They're rated as being more depressed. But is that necessarily true? I mean,
no, some people are more expressive and vocal than others.
Exactly. So someone who is very stoical, for example, may not appear to be very depressed, but may actually be much more dysfunctional than someone who is expressing their emotions. So that's just an example to show you that actually the validity of the scales on which all these trials are based and all these judgments are made that license these drugs is completely insubstantial.
I once saw my GP, and I had lovely, amazing GPs in my lifetime, about something, and she looked at me and she said, "You look fine to me." I went back a month later or so, and I made sure that I was dramatic about it to get what I want.
Yes.
Because it was a true symptom. I was really struggling about something that I was more vocal. I just thought I should show poise and respect and be scientific about how I feel. You look fine to me. Okay. So, yes, another angle is how funding from pharma companies shape the agenda. I read about pharmaceutical marketing, sponsoring of psychiatric conferences, funding of research. Yeah, this is, I think, legitimate. They should fund research. They earn a lot of money. And even ghost-writing articles. How have these practices affected the scientific discourse?
So they've massively affected it across medicine, but I would say particularly in mental health, and particularly by promoting this idea that mental health problems are like other medical conditions and can be treated by drugs and can be investigated with simplistic research studies that use these simplistic rating scales. So the fact that so many of these studies are done and published creates the impression in itself that this is what mental health problems are. And because pharma can fund and publish far more studies than, say, a social scientist who is trying to think about the nature of, for example, depression in a different way, and because they can get them into bigger, higher profile journals and because they can publicise them more, this is partly what has skewed our understanding of depression towards this scientific medical view.
You once said that psychiatry is a profoundly political enterprise. In what way?
So I believe that mental health problems are what Thomas Saz, the famous anti-psychiatrist, once called problems of living. They are often, not always understandable, but often understandable struggles that people have with the world, with the circumstances that they find themselves in. And if we call those struggles an illness or a disease, we deprive them of having any meaning. We empty the meaning out of them. We focus the interest on the disease process rather than understanding these situations as reactions to circumstances and as signals that there might be something wrong with our circumstances. So, for example, the fact that so many people are depressed, anxious, and distressed at the current time, and the rates of people presenting with these problems seem to be ever increasing, should, I think, make us reflect on what it is about modern society that makes people feel so uncomfortable, that makes people feel so worried and so pressurized and so unhappy. But instead of doing that, we're labeling all these people as having medical conditions and giving them drugs or other medical treatments.
What do the high rates of mental health in society today and how we approach them say about our culture and our values? Picking up from the last point you have said, what does that say about us?
Yeah, I think mental health, the medicalisation of the problems of living is a convenient strategy that has been used by many different sorts of government and regimes across the world because it diverts attention from the problems that are happening in the society. So, I think that's one of the main reasons that our medicalised view of mental health problems is so popular and has become so entrenched. It enables governments to take their eye off the ball, to not have to worry about the fact that many people are really struggling because it's difficult to find secure work anymore. Social networks have been fragmented. Many people are lonely. Many people feel that because we live in an increasingly financially unequal society, many people feel that they're failing, even though by, other standards they might be doing quite well. People, the fact that not so many people subscribe to a religion anymore means that many people struggle with finding meaning and purpose in life. And because other collective institutions such as trade unions have become less powerful, that also means that another avenue, sort of collective action and political action and campaigning, has become less easy for people to access. So, I think there are all these aspects of modern society that make life difficult for people, make it challenging, make it difficult for people to find meaning and purpose. And these all contribute to mental health problems, contribute to people feeling anxious and depressed and stressed. And then what we're doing is we're saying, this is a medical problem, these people have medical problems, they need to go and see their doctor and get an antidepressant, instead of saying, how do we need to change society to make people's lives better?
Before people take antidepressants, most of them are in a very bad shape. We live in a welfare state here, welfare country in the UK. Whose responsibility to help those people?
I think that understanding mental health problems as medical problems is mistaken. I'm not denying that people struggle with their emotions and their thoughts and the ways that they behave, and would like them to be different. And some people have severe and significant difficulties and will need care and support and help with those. I think the way to approach mental health problems, I think what's wrong at the moment is we have this medical model. We think that means we need to give people a diagnosis and then we need to treat the diagnosis. So, you've got depression, we'll give you a drug for depression. You've got anxiety, we'll give you something for anxiety. You've got bipolar disorder, we'll give you a drug for bipolar disorder. Instead, I think we need to understand what the nature of individuals' problems actually are and help them to resolve those problems. The vast majority of people who have depression and anxiety in this country have very understandable reasons for feeling as they feel. They are struggling with, financial problems, work problems, relationship problems, housing problems, etc. And they need help with those. There are some people who, I'm always asked this, but what about the people who, get depressed for no reason? And that does happen. I'm not saying that doesn't happen, but the vast majority of people, actually, the reason is really obvious. And we need to help them with whatever it is that's led them, whatever problems it is that has led them to feel as they feel. Then there are some general things that people can do to help improve their mental health. One of them is exercise. Exercise has been shown in a lot of proper randomized controlled trials and other reputable studies to help with people's mood, to help improve symptoms of depression and anxiety. So exercise is a really good thing to do. Therapy, of course, psychological therapy can help some people. Particularly, I think it can help with people who've had gone through traumatic events and experiences and need to process those. And it can help with people who are not sure why they're feeling how they're feeling and may need to, explore aspects of their lives to try and work out what it is that might need to be changed to make them feel better. So therapy can be helpful. I'm sure that things like eating well, sleeping well, these are all likely to be important for your mental health, getting good treatment for your physical health problems, having good supportive relationships with other people, doing something that makes you feel like you have some value and some purpose in the world. I think that's another really important factor for helping people to lead fulfilling lives. So that's the way that I think we should approach mental health problems. Then, as I've said, there will be some people who get really severe mental health problems who, really find it difficult to, get themselves going. They might, even have psychotic symptoms and start sort of losing touch with reality. And those people need looking after, caring for, keeping safe until such time as they start feeling better. Sometimes they might need, if they're really not sleeping or really anxious or agitated, they might benefit from temporary treatment with a sedative just to calm them down a bit. I've talked about how antipsychotics can help to suppress sort of people's preoccupation with delusional ideas and experiences.
Yeah. Here's a thought. Can I approach my GP and say, this is how I feel, I can't function, I can't look after myself or my family, I can't ride it out, and I prefer not to take drugs at this stage? Is there a way I could be referred to counselling or some sort of talking therapy? Is that within my rights? Is that a route I could take?
So we are very lucky in this country in that we have a national psychological therapy service under the NHS. So yes, absolutely, you can be in whatever area of the country you live in. There is you will have access to some psychological therapy, depending on how badly affected you are. The sort of first level of that often consists of an assessment and then some therapy that's conducted online or over the telephone. And then, if you don't improve or if your problems are more severe, then you can access face-to-face and more intensive therapy, although in many areas there's a waiting list for that more intensive level.
Course.
But the lower level therapy does have a waiting list, but not a very long waiting list, and it is available to everyone. And I think that's an amazing thing. I mean, it has been criticised by therapists who I know feel that, we should have better access to more in-depth psychotherapy, and I certainly think that's important for some people. But I do think that it's a good thing that we have this therapy service that's available to everyone. And another thing to say is that you shouldn't have to be on medication to access mental health services, and many mental health services have employ support workers, sometimes peer support workers, that is people who've had their own mental health problems, to support people who are in the sort of situation you're describing, to particularly to help them access things that are out there in the community that might be beneficial for them, but that they might struggle to get out to when they're in an emotionally debilitated state.
Professor Moncrieff, some psychiatric survivors report that discovering your work was pivotal in helping them understand or rethink their diagnosis. I'm aware that after your serotonin paper, some critics labeled you a contrarian. You don't come across as a showy or confrontational person. How was it for you in the eye of the storm?
It was quite something after the publication of that paper in 2022. My phone was buzzing from journalists phoning me the whole time, and calls to be on various programs. And I was flooded with emails, positive emails from people who said, oh yes, I've thought this all along, and emails from people who were taking antidepressants who were upset to hear that actually this idea that they had a chemical imbalance was not established, and some of them said to me that they would preferred that I hadn't published it or hadn't publicised it. I think because it unsettled the view of themselves that they had come to adopt after having it presented to them by their doctors or by the online sites and the media. So that was interesting. And then I had colleagues of mine saying that I, shouldn't speak to the media, that I didn't have any right to say anything at all about antidepressants. All I should say is just that our paper didn't find current evidence of links between depression and serotonin. And clearly, if I'd said to the media, but I have nothing to say about antidepressants, that would have been taken as an endorsement of them. And I believe that, one of the reasons I did the work on the serotonin research in the first place was to highlight to people that, your current understanding of antidepressants is not founded in evidence. There are other ways of understanding what they do, and you need to understand this in order to make a properly informed decision about, whether you want to take this drug or not. So clearly I wasn't going to not talk to the media about that, but that upset some of the people in my profession that I did. So yes, it was an interesting time. I was boosted, of course, by the people who contacted me to say, I've thought this all along. I'm so pleased that you've said this. And people who I now know a lot of people in what is sometimes called the prescribed harm community. Those are people who have taken antidepressants or other drugs and had really negative long-term consequences, such as these protracted withdrawal effects or the persistent sexual dysfunction that can sometimes occur after people have stopped taking antidepressants.
And despite that aggressive response to your paper, do you consider yourself an optimist?
I think I fluctuate. I fluctuate between
Depends on the day.
Yes, between feeling that that this medical model of mental health is so deeply entrenched, we'll never be able to shift it. And feeling that things like the internet, the ability for people who have had negative experiences with medical treatments like antidepressants to link up and to highlight these problems and to warn people about the negative consequences of taking these medications, and to warn people about how we haven't been properly informed about the nature of these medications in the first place, is really powerful and is going to make a difference. So, yeah, it depends what day you get me.
I understand. Professor Joanna Moncrieff, you bring such courage to a field that often resists uncomfortable questions. Your work reminds us that being scientific also means being ethical, and that respecting patients begins with telling them the truth. And by questioning simplistic narratives and by insisting on honesty on what we can do and what we can't do, you give patients something very, very valuable. You give them dignity, agency, the right and the choice to understand their own suffering. There's something beautifully philosophical about your teaching. To you, progress doesn't come from certainty. It comes from our willingness to ask difficult questions. And this might be one of the most important contributions anyone can make to mental health.
I agree. Science is also about curiosity. And I want to encourage curiosity about all the myths that we've been told, all the things that we've been told, and curiosity about the nature of mental health problems, the nature of the treatments that we dish out to them. I want to encourage curiosity, questioning, and debate.
Thank you so much for being with us today.
Thank you.